This is, of course, my passion. This is my disclosure. And I'm going to give just an overview, epidemiology, talk about burden of disease, and not only in childhood, but women in the childbearing period, and some of the diagnostic challenges and management challenges. So why do we need to discuss hepatitis C? I'm going to focus on hep C, and I'm going to touch briefly on hepatitis B as well. The disease is mostly asymptomatic in children. They do not undergo regular biochemical testing or donate blood. And many of those children have normal ALTs, and the risk factors are usually not sought by the care providers, while extrahepatic manifestations are usually rare. But what about the burden of disease? It's largely unknown in this population group, and we've conducted a modeling study in collaboration with Homi Razavi and his team, and we presented that in EASL last year. The data we managed to correlate at that time showed that the prevalence rates below the age of 15 years was highest in the low-middle income countries, and particularly in sub-Saharan Africa, North Africa, Middle East, and those are the low-middle income countries representing around 85% of the infections. While most of the infections, more than 50%, were in countries like Nigeria, Egypt, Pakistan, India, China, and Ethiopia. However, when we updated the data, just yesterday I received the latest data, we collated more data during this year, and more national surveys were done from different countries. The prevalence and the viremic children dropped from around 6.6% to around 3.5% on average. And that's below the age of 15. Now we're stratifying per age, and we're looking at prevalence rates also between ages 15 and 18. And we can see a spike between 15 and 18 years, and that's because of the high-risk behavior. So it's very important that we consider treatment of children before the age of high-risk behavior. Looking at the global worldwide population of 7.5 billion, with around 160 million currently HCV positive, and almost 3 million per year will become hepatitis C positive born to mothers infected. The previous estimate in the US showed that with 5 to 7% transmission rate of perinatal transmission, around 7,000 newly infected children are born yearly. But I think the updated data from John, I heard from CDC, is around 1,600 per year. That's the new estimate for those born with hepatitis C. I think it's still a significant number, considering that children play sports, they play together, they are likely to infect others, infect their families. So it's important that we consider children when we consider any elimination model or any elimination program. And those are some striking statistics in North America, looking at 31,000 between ages 6 to 11 years, 101,000 infected between ages 12 to 19 years, lowest in Canada, around estimate 6,600 in Canada, around 46, between 23 to 46,000 in the US are estimated to be infected with hepatitis C, but also the chronic infection has a 26-fold increased risk of liver-related deaths. And I think this is a very important number. The most common route there is the vertical transmission, and the costs are astronomical. It's expected that the 10-year costs would be up to $336 million US. What about the women in the childbearing age? Because those are the women who are infected and might have a risk of transmission of 5 to 7%, and in some studies they look at 10% perinatal transmission. This also study, we're starting with Homi Razavi and his team, and these are the earlier reports from 29 countries who are responsible for around 80% of the infections, and an average of around 13 million viremic HCV infections among women in the childbearing age, aged 15 to 44 years, and mostly from China, Pakistan, Russia, Egypt, India, and then Nigeria. Those are responsible for 50% of the infections. And this is the report mentioned this morning by John Ward from CDC, looking at this mortality morbidity weekly report in 2016, looking at a higher prevalence of HCV detection among women in childbearing ages, children below the age of 2 years. Totally in the US, around 22% in women and around 14%, but also in Kentucky, more than 200% increase, and in children, more than 151% increase. And I think a similar report is coming also from Philadelphia. The birth certificate data coming during the same period showed the proportion born to HCV-infected mothers increasing 68% in the US and almost 124% in Kentucky. This shows very clearly that we should start and consider screening of children and treatment of children as early as possible in the presence of safe, highly efficacious drugs. And this has a lot of implications, of course, on public health and the testing guidelines for both children and pregnant women. And this is a nice study looking at the potential pathway for infection during the perinatal period, where it is hypothesized that there are receptors for the hepatitis C on the trophoblasts, and that allow transmission of hepatitis C through the villi. It's something similar like the IgG transport with other infectious diseases. What about the pregnancy outcomes in women who are infected with either B or C? Also in one of the recent studies, they look at, for both B and C, a preterm birth, low birth weight, premature rupture of membranes, gestational diabetes, possible small increase in congenital anomalies. While in hepatitis C, and I think this is seen often in Egypt as well, cholestasis of pregnancy, NICU admission for the baby, and neonatal abstinence syndrome in those who are injecting drugs. So this is, I think, also important with the transmission risk of 5.8%, which doubles in case of HIV co-infection and in case of mothers who have high viral loads. What about prevention? We do have prevention for hepatitis B, transmission from mother to infant. We do have vaccination. We do have immune prophylaxis. We do have antiviral agents like tenofovir, with the most recent study of Calvin Pan in New England Journal showing that it's very effective in decreasing the risk of transmission if given at 32 weeks. While hepatitis C, we need to improve the HCV risk screening, including child born to HCV-infected mothers. No therapeutic agents are yet available either for small children or for mother to prevent mother-to-child transmission, which has a risk of up to 10%, and it can be minimized by avoiding fetal scalp electrodes and birth trauma whenever possible. This is the study I was just mentioning by Calvin Pan, showing that those were 200 mothers who had DNA more than 200,000 international units, and they were randomized 1-to-1 as usual, immune prophylaxis plus vaccination versus tenofovir 300 milligrams per day from 30 to 32 weeks gestation, and with a follow-up of up to 28 weeks and a treatment up to 4 weeks after delivery. All received immune prophylaxis, and the safety profile was similar with the standard of care and those receiving the tenofovir. However, the percentage of those infected with Hep B was way much lower in the tenofovir group. So these are the data for the women in the childbearing period who've been enrolled in our national Egyptian treatment program. We extracted data for women who were diagnosed with hepatitis C and were treated through the national program. And out of the whole treated group, we had 210,000 women. Of those, 55,000 were between ages 18 and 45 in the childbearing period, and 51,000.6 were treatment naive. The rest were above 45 years. And those are the drugs that they received, the medications. Most of them received interferon riba. That was in the earlier part of the national program. And then the rest received either triple therapy plus for 6 months, interferon soft riba for 3 months, sim-soft or soft riba. And they were mostly with abnormal echo pattern on ultrasound, but very few of them were cirrhotic. And those are the comorbidities that were reported by those women. So back to this slide, why do we need to diagnose hepatitis C? We need to treat children as early as possible. In Egypt, the Egyptian population, almost half of the Egyptian population are below the age of 25 years. We have a 92 million population right now. 1/3 of the population are below the age of 15. More than 100,000 are less than 15 years may be chronically infected with hepatitis C, and more than 10,000 are born on yearly basis with hepatitis C. The last demographic health survey showed a 7% HCV viremia, as Professor Dose mentioned earlier this morning. Who are the children at risk? In Egypt, those receiving recurrent blood transfusions, undergoing multiple hospitalizations, undergoing multiple invasive procedures, children born to HCV-infected mothers with an infected household member, and those adolescents with high-risk behavior or illicit drug use. There is underreporting for adolescents with illicit drug use. And those are some of the prevalence studies. I'm going to go through them very quickly. We could see in some of the earlier studies before 2010 that the mother-to-infant transmission was seen in 10% at ages 2 months. And in some of the prospective studies in Egyptian villages showed an incidence in the first 5 years of life of 3.8 per 1,000 person years. Other prevalence studies looked at around 2% population of children infected. Some other studies showed a high intrafamilial transmission, particularly sibling-to-sibling transmission being highest among the families with 31%. And in another study of 500 children, they showed a prevalence rate, those without previously known risk factors, of 5.8%. However, the MOH survey, the Ministry of Health survey in 2009, showed around 0.5% for those aged 1 to 15, and in the latest demographic health survey, they showed a prevalence of 0.2 to 0.5% between ages 0 to 15, with the highest prevalence above the age of 10 years. What about the multi-transfused population? We still are facing problems with the multi-transfused population. We're still seeing acute hepatitis in patients receiving multiple transfusions like thalassemics and hemophiliacs, and some of them resolve, but a lot of them, they go through the chronic hepatitis phase because of other comorbidities and risk factors, including iron overload in thalassemics. But the prevalence dropped after the screening of blood in 1993 to 23 to 50%, still though very high, because most of the blood in Egypt, around 30%, only screened by NAT testing, and the rest are screened by ELISAs. So some of those who are donating blood might be in the window periods. So we have also a lot of studies showing a high prevalence rate of hepatitis C in children undergoing chemotherapy for hematological malignancies and other malignancies. The cancer population, as well as those undergoing transplant, bone marrow transplantation, is quite high. And not only this, we're seeing also occult hepatitis B in this population of HCV-infected group. And in fact, the hepatitis B takes the upper hand in the immune-suppressed population. And we very often, after we clear the hepatitis B in those receiving chemotherapy, we start to see the hepatitis C at a later stage. Those are the screening options and available options for children. It's a bit difficult to take blood samples for small children. So we conducted a study with OraSure Quick, testing HCV viremia in children, and they were an immune-compromised population, both with hematological disease and malignancies, versus normal children, and sensitivity and specificity was very high, even in the immune-compromised population. However, the biggest problem with the OraQuick is its price. It's prohibitive, and it's very difficult to start and standardize it for screening of all children. We are doing fibroscans on regular basis for children, and we have cancer survivors who have very high fibrosis staging, and they progress the liver disease very fast. We use also non-invasive alternatives like APRI and FIB4, while the newborns are not screened before 18 months. What about the natural history? We know that children most likely spontaneously clear the virus in more than 50% of the cases, acquiring perinatally. However, HIV co-infection increases progression of liver disease and lots of comorbidities in children who have high prevalence rates like cirrhosis, cancer chemotherapy, among those who have highly progressive liver disease. And those are some examples of how we still utilize liver biopsy to see some of the comorbidities and some of the children who have comorbidities. Like in this, for example, this is a young patient, 10 years old, with relapsing acute leukemia and HCV-related reactivation and a fibrosis of 3/6. And we could prove that the multiple flares happening during cancer chemotherapy. I would like to remind you that children mostly have acute leukemia, and they take chemotherapy for at least 4 years, which is a very long time, so they suffer from continuous flares and regular flares and reactivations for Hep C, and this is positively correlated with progression of liver disease and advanced liver disease. And those are other examples of how we have iron problems as well, iron overload, not only in the thalassemia groups that are multitransfused, but also in the chemo patients. In a 7-year-old on the left side, on the right side, a 16 years old, even with Wilms tumor. She removed her tumor, and she came back later. It was probably related to Hep C because she did not receive chemotherapy except for a few months. And those progress more, even faster than those who do not have iron overload or siderosis. This is also another complex case who was cured of neuroblastoma, which is a childhood solid tumor malignancy. And she had hepatitis C, and she had comorbidities of Hep C, secondary autoimmune hepatitis, as well as iron overload. And we could only diagnose those problems by liver biopsy. Now, actually, this girl received first a chelating agent for siderosis, improved, and then she got treatment for autoimmune hepatitis, and now she's currently receiving treatment for hepatitis C, and she's negative. I just saw her last week after 4 weeks of treatment for hepatitis C, and I treated her actually off-label. She's 15 years old. Others, like steatosis in diabetic children, we see that very often as well. We could see also steatosis in a lot of cases with hepatitis C, both with malignancies and without, and they're much less responsive to treatment than those without steatosis. What about extrahepatic manifestations? We still encounter extrahepatic manifestations in children, unlike what is taught in the adult population. The one on the left side came with very special, unique presentation for genotype 4, which is necrolytic acral erythema, and she presented at the age of 12 years. She was cirrhotic. Both had vertically transmitted disease, and both had both parents infected. She lost her mother, the one on the left side, and she had a very advanced liver disease, had interferon, and then progressed to end-stage liver disease, was transplanted in China, and then she is married now, cured on hepatitis C with DAAs. The other one on the right side has lichen planus, which is quite rare in children, also Hep C infected. He's F3, and the skin lesions are itchy. He's affecting the quality of life, so we need urgent treatment. So there is a very strong rationale to treat patients and children. I recently also had a child with incapacitating bone pains, 12 years old. And we had all scans and bone marrows and PET scans. They were negative. And I treated him off-label. He was 54 kilograms, and the pains completely disappeared after 2 weeks. He was on continuous tramadol for the pains. So we do see extrahepatic. It's affecting the quality of life of children. We see affection of school performance, neurocognitive dysfunctions. All those would point to the urgency for treatment of children. They have better tolerance to medications. Those medications are safe. We don't have to give them interferon anymore and affect the quality of their lives with interferon and their growth. And we need to treat children with comorbidities. We have a very nice program in Egypt that's funded by one of the non-governmental organizations. We treated in 3 phases over 1,000 children. This is the first phase, and we had a lot of them missing, not coming back for SVR. However, in the final phase, we had an SVR rate of around 62% for those selected patients who are IL-28BCC genotype. However, it is important to understand that this is affecting their life dramatically to give them still interferon. So children are definitely better candidates. We need to avoid disease progression and avoid social stigma. We need to improve the fatigue and school performance, extrahepatic manifestations and comorbidities, and decrease the burden would avoid transmission. We need cure as prevention, and curing a patient, of course, would save a lot of money. There are lots of contraindications still to interferon, but those contraindications do not apply to the current DAAs. We need to manage all the transmission aspects and delay the progression of liver disease as much as possible and vaccinate children all against hepatitis A and B. And those are the currently registered clinical trials, very few compared to adults. There is also one recently for the 2D drug for AbbVie. We have an investigator-initiated trial in the immune-suppressed population receiving chemotherapy with the soft lead. And we're starting our own trials in Egypt with the soft DAC, doing PK studies, and among other drugs. We're not waiting for the global studies. And those are the challenges and gaps and future outlook. We need to prevent vertical transmission for both hepatitis B and C. We need to screen all pregnant women. We need early treatment of women in the childbearing age. We need point-of-care diagnostic tests that are feasible, easy for children. Early treatment of children. Pediatric clinical results will not be available or registration before 2018 or even 19. We need to avoid stigma. And compliance to adherence for HPV therapy is still one of the challenges. The economics of manufacturing and availability of pediatric formulations is a huge challenge. And access in low and low-middle income countries to prevention and treatment is a challenge. So this is the key to success for all children. We need to help them with better diagnosis and prevention, as well as care and treatment. I would like to thank all the collaborators, including the NGO, Saweer's Foundation, and my fellow colleagues in National Committee, as well as my university. Thank you very much.